Ventilator-associated pneumonia.
Ventilator-associated pneumonia.
Ventilator-associated pneumonia is a subtype of hospital-acquired pneumonia or nosocomial pneumonia which occur in people who are receiving mechanical ventilation. It develops more than 48 hours after tracheal intubation and IPPV, causes greater than 50% of ICU infection. Definition of ventilator-associated pneumonia. Radiological, 2 or more serial chest X-rays or computed tomograms, CTs, with appearances suggestive of pneumonia for patients with cardiac or pulmonary disease. One chest X-ray or CT is sufficient in patients without underlying cardiac/pulmonary disease. Systemic, at least one feature, fever greater than 38 degrees C with no other cause. Leukopenia, for X109/L white blood cells, or leukocytosis, /equals 12X109/L white blood cells. Pulmonary, at least one feature, or in the absence of supportive microbiological data, at least 2 new onset of purulent sputum, or change in character of sputum. Worsening gas exchange. Cough, or dyspnea, or tachypnea. Suggestive auscultation, rales, bronchial breath sounds, rhonchi, or wheeze.
Suggestive auscultation, rales, bronchial breath sounds, rhonchi, or wheeze.
Pathophysiology. The key to the development of VAP is the presence of an ETT or tracheostomy, both of which interfere with the normal anatomy and physiology of the respiratory tract, specifically the functional mechanisms involved in clearing secretions, cough and mucociliary action. The endotracheal tube allows free passage of bacteria into the lower segments of the lung in a person who often has underlying lung or immune problem. Bacteria travel in small droplets, both through the endotracheal tube and around the cuff. Often bacteria colonize the endotracheal tube and are embolized into the lung with each breath. Bacteria may be brought down into the lungs with proceedings, such as deep suctioning or bronchoscopy. This leads to the macroaspiration and microaspiration of contaminated oropharyngeal secretions that are rich in harmful pathogens. Normal oral flora start to proliferate and are able to pass along the tracheal tube, forming an antibiotic-resistant biofilm which eventually reaches the lower airways. Critically unwell patients exhibit an impaired ability to mount an immune response to these pathogens, leading to the development of a pneumonia. Bacteria may be brought down into the lungs with proceedings, such as deep suctioning or bronchoscopy. This leads to the macroaspiration and microaspiration of contaminated oropharyngeal secretions that are rich in harmful pathogens. Normal oral flora start to proliferate and are able to pass along the tracheal tube, forming an antibiotic-resistant biofilm which eventually reaches the lower airways. Critically unwell patients exhibit an impaired ability to mount an immune response to these pathogens, leading to the development of a pneumonia. Causative agents. Microbiological flora, multi-drug-resistant bacteria are responsible for VAP. They are Pseudomonas aeruginosa, Klebsiella pneumonia, Staphylococci, which are resistant, Actinobacter species, Enterobacter, Citrobacter. Virus and fungi may also be the causal agent. Causative agents. Patient-related. Age. Cardiorespiratory disease. ARDS. Coma. Multiple organ dysfunction syndromes. Ventilator-related. Duration of IPPV more than 7 days. Tracheal cuff pressure less than 20 cmH2O. Reintubation. Tracheostomy. General ICU care, supine position. Invasive devices. Aspiration. H2 receptor antagonist. Indiscriminate use of broad-spectrum antibiotics. Sign and symptom. Typical symptoms of pneumonia will either be absent or unable to be obtained. The most important signs are fever, low body temperature, new purulent sputum, hypoxemia. Diagnosis. Increasing number of WBC on blood film. New shadows, infiltrates, on a chest X-ray is indicative of pneumonia. Blood culture may reveal the organism causing VAP. Quantitative culture of specimens obtained by tracheobronchial aspiration. Lavage on brush specimen may reveal the microorganism. Rule out non-infectious cause of chest infiltrate. Various non-infectious conditions can result in pulmonary shadow similar to ventilator-associated pneumonia, and should be ruled out. Atelectasis. It is common in postoperative period following upper abdominal surgery due to hypoventilation. Left lower lobe atelectasis is following coronary artery bypass grafting. Radiological signs include displaced fissures, crowded bronchovascular markings and shifts in the positions of the HeLa, diaphragm, and mediastinum, and increased density or radiopacity of the lung tissue. Fever and leukocytosis may not always be present. Aspiration. It occurs in patients with impaired consciousness, regurgitation of enteral feed and microaspiration around endotracheal tube cuff. Right lower lobe is commonly involved. Infiltrates may take up to 12H to appear in the chest X-ray after the event. History of vomiting or bile-colored tracheal secretions on suctioning is a clue to the diagnosis. It may be a purely chemical pneumonitis initially, caused by acidic gastric contents. Pulmonary embolism with infarction. It is generally acute onset in the background of risk factors for deep venous thrombosis and pulmonary embolism, PE. Diagnosis can be confirmed by CT pulmonary angiography. Pulmonary hemorrhage may resemble dense alveolar consolidation. Generally, endotracheal AT secretions are blood-stained. Coagulation profiles or other immunological markers may be deranged. Cardiogenic pulmonary edema. Acute respiratory distress syndrome, ARDS. Fluid overload. Hypersensitivity pneumonitis. Drug reactions, cyclophosphamide, methotrexate. Cryptogenic organizing pneumonia, history of recent viral infection. Radiation pneumonitis. Lung contusion. Treatment. Treatment of VAP should be matched to known causative bacteria. In suspected VAP, when causative agent is not known, then broad-spectrum antibiotics are given. When particular bacteria and its sensitivities are determined, then specific antimicrobial therapy is given. Possible empirical therapy combination include vancomycin/linezolid and ciprofloxacin. Cefepime and gentamicin/amikacin/tobramycin. Vancomycin/linezolid and ceftazidime. Carbapenem. E.g., imipenem/meropenem. Preventive measures. Good oral care. Regular oral care with basic hygiene aims to reduce dental plaque colonization with aerobic pathogens. Appropriate semi-recumbent positioning of patients, with a 30 to 45 degree head-up approach, reduces the incidence of microaspiration of gastric contents. Stopping stress ulcer prophylaxis in low-risk patient. Selective decontamination of digestive tract. Limit exposure to resistant bacteria. Discontinuing mechanical ventilation as soon as possible. Early weaning protocol with regular sedation breaks. Avoidance of routine or scheduled ventilator circuit changes. Subglottic suction ports have been shown to reduce the incidence of VAP. Maintenance of endotracheal tube airway cuff pressure at 20 to 30 cm H2O and the use of positive end expiratory pressure. Proper hand washing, sterile technique for invasive procedure. Isolation of individual. Daily assessment for extubation. Monitor VAP rates. Local input from microbiology regarding antimicrobial selection and antimicrobial resistance patterns.